I'd like to spend the next 45 minutes or so telling you about a little project that I got interested in the 1990s. I don't have any conflicts to confess, but I do have a paid political announcement, particularly for the younger and mid-career people in the audience. There is an excellent course that is sponsored by the American College of Surgeons and a number of specialty surgical societies at the Heller School in Brandeis on health policy and leadership. And that many of the surgical specialty societies provide scholarships to attend. I think Society of Vascular Surgery does, Pediatric Surgery does, New England Surgical, ACS. It's run by John Chilingerian and Stuart Altman, who's kind of the Yoda of health policy. Did you do it, Matt?
I did.
Yeah, David was in my class. So I strongly encourage you to apply and attend that if you have a particular interest in healthcare policy and leadership. So, as I said, my interest in this goes back to actually when, to the early 90s, when Bill Clinton was elected. You may recall that there was something of a mandate for healthcare reform in the early 90s, and I remind people kind of much to the shock and awe of surgeons, is that the American College of Surgeons actually endorsed a single-payer system in the early 90s. We've come a long way in the last 17 years. So let's go back. Let's go to the 2008 election and what was the impetus for healthcare reform with 2008. Well, really, it was a problem with access to care. We had 25 million people uninsured in the United States, and people were, finding that the number one cause of bankruptcy and financial failures for families was lack of health care, and the cost of health care had accelerated to a point that something needed to be done. The other problem that began to really start to be talked about in the late 2000s was healthcare quality and the outcomes from healthcare in the United States. And you may remember a report called Crossing the Quality Chasm that was developed by the Institute of Medicine, really about problems with quality of healthcare in the United States and outcomes. But the most important thing was political will. And in 2008, we elected Barack Obama as the president. If you recall, the economy was in shambles, and the Democrats swept all three houses of the federal government. And so there was some political will to take this project on in 2008, and as we all remember, it led to the development of the Affordable Care Act. So the Affordable Care Act was fundamentally solved the problem of access to care, okay? Didn't really solve the cost or quality problems associated with health care. And access to care is fundamentally an insurance problem. Most employed Americans have an employer-based health insurance, and we'll talk about how we got to that point. Medicare and Medicaid and the VA provide coverage to the rest who have coverage. And in 2008, there were close to 15% of the population without any health care. Now, if you looked at that 15%, many were young, healthy adults who chose not to have insurance, and in fact, 40% were between the ages of 19 and 29. So let's go back and kind of revisit how we got to our kind of unique American healthcare system, and you'll get an opportunity to see that it truly is quite unique. So if you go back to 1912, Theodore Roosevelt decided to run on the Progressive Party ticket, or the Bull Moose Party ticket, and he was really the first national candidate to endorse some kind of a social health insurance. There was no real plan associated with it, but he talked about the benefits of somehow ensuring the social welfare of the population. Really, healthcare insurance started with prepaid hospital insurance. It was introduced by Baylor Hospital in 1929. This ultimately became Blue Cross, okay? So it expanded, and you just pay a flat fee, monthly fee, and Baylor Hospital would insure you for your health care needs. 1935, the Social Security Act included some coverage for maternal and child health, but really omitted broader insurance. And in fact, FDR did have plans to broaden all of the social network, healthcare net insurance programs that he was developing, but he actually never got around to finishing it. In 1939, the first physicians insurance plan began to arrive on the scene, and that was the first Blue Shield. So again, like the Baylor program for hospital, groups of doctors started to band together and sold insurance, again, almost on a capitated model, so that people could go to the doctors for a flat fee. The big thing, and the reason why it's called out in red here, that fundamentally changed health insurance in the United States was in 1943, when Congress made employer-based health insurance tax exempt. So this was a time of wage and price control freezes during the war, and the economy was at full employment, as you might imagine, because everybody was fighting the war or working in a factory to make something that's going to support the war. And so manufacturers, employers were looking to have an edge where they could employ people, and because of wage and price control freezes, they couldn't pay them more money. So they got the Congress to make employer-based health insurance tax exempt, and we have, since 1943, we have carried this tax exempt status for employer-based health insurance forward. Well, this is kind of driven the entire direction of how healthcare has developed in the U.S. 1943, Wagner Murray Dingle was introduced, proposing the concept of universal health coverage. Again, the president, FDR, supported it, but he had a lot on his plate in 1943, so that never got done. 1947, Truman called for a national health insurance program, national health plan. You may recall that when Johnson signed Medicaid and Medicare in 1965, he had Truman sitting at his side, because this was always something that was very important to Truman, but he did not have the political horsepower in Washington to do that. 1956, we began to see something that began to approach a VA system for the military Medicare. So that was a kind of Medicare type program that provided health insurance for military dependents and the men who are coming home from the war. 65 was Medicare and Medicaid, a huge deal. Medicare was kind of a pay into it system, and Medicaid was for the poor. And again, I think that's a relatively important distinction, because we, as a country, still feel very differently about Medicare than we do about Medicaid. Medicare is something we deserve when we retire, and Medicaid is often thought of as an entitlement or a handout. Medicare expanded in 72 to include those under 65 with disabilities, and a carve-out for chronic renal failure. And there's been some discussion about whether or not we ought to have other carve-outs in our healthcare system. 1983, when I was a resident at the Mass General, the concept of diagnosis-related groups, or DRGs, was introduced. We had sat in a room like this, all as residents, and we were all told the world was going to end. Okay? This was the first time that the federal government was imposing a fee schedule on the payments for health care. Under Medicare and Medicaid 65, the agreement was usual and customary fees, because both Medicare and Medicaid were very strongly opposed by organized medicine. They were concerned that this was socialism, and they were also worried about protecting their fee structure. So Medicare and Medicaid, usual and customary fees. 83 DRGs, first time the federal government says this is what you're getting paid. We used to, just like you were talking about dot phrases here this morning, we were told what we had to put in our documentation, and hospitals developed huge coding departments and things like that to work under the DRG system. 1993, Hillary Clinton tried to put a health plan together that fizzled, member managed competition. 1997, Medicare Advantage was established and the Children's Health Insurance Program was developed. And the CHIP program is kind of a donut hole filler. Medicaid is for the poor up to a certain level of the poverty level. It's now 138% of the federal poverty level. CHIP is for families that don't qualify for Medicaid but don't have enough money to buy insurance. It's usually for a family of four, it's around $45,000. CHIP was just, as you know, reauthorized for 6 years in the last spending bill. The Medicare drug prescription benefit was created in 2003. And then in 2009, 2010, the Affordable Care Act was passed, and the major Supreme Court challenge to the ACA was in 2012 when the Supreme Court found it constitutional. So that's kind of how we got where we are, okay? So there are two things you need to understand about health insurance that's very important. One is something called adverse selection, and that is a situation where an individual's demand for insurance is positively correlated with their risk for loss. So insurers, prior to the ACA would exclude patients with pre-existing conditions. They only wanted to take the good risk patients, and that was that condition was put into the ACA, that you can't be excluded from health insurance for pre-existing conditions. The other piece is moral hazard, and that is if you're not fundamentally paying for something, you will utilize it more. And again, I think this is important in the insurance market because if you have employer-based insurance, you don't really have the sense that you're paying for something. So if you think about copays and deductibles, which is really a way to try and give patients a skin in the game and avoid overutilization, it's to deal with this moral hazard problem. So what's the problem with not having health insurance? And I think that we've seen with the most recent budget bill that they're taking away the mandate to buy health insurance. Not that it was a particularly effective mandate, but here's just one article that shows that if you have no insurance, your outcomes from trauma are decidedly worse. How much do we spend on health care? Well, it's up to $3.3 trillion now. And the interesting thing is this is the annual percent increase in spending. We're at about now 18% of gross domestic product. There's an economist at Princeton called Yoyo Reinhardt, you may have heard of. In 1990, Yoyo Reinhardt predicted that by 2020 we would be spending 20% of our gross domestic product on health care. Everybody thought he was completely crazy. We're going to be there. We're going to be right around 20% in 2020. So this is our current spending in health care. It varies a little bit, but fundamentally it's been 2 to 5% increase fundamentally since Medicare and Medicaid were introduced in the mid-60s. We're very different from other countries. We spend about 30% more than every other country of our. So this is, this is percent of the gross domestic product, and these are all the developed countries, and you can see we're way up here. Now, they are sneaking up on us, and the national health insurance in Britain is under considerable duress because of the cost of health care in Britain, and one of the big motivators for Brexit actually was somehow that was going to magically create money that they could put into the national health insurance system there. We have a kind of funny way of spending our health care. This says that the top 50% of the population spend 96% of the health care dollar. Actually, if you look at, it's even more extreme than that. The top 1% of the population, and I don't mean by income, but by spenders, spend 20% of our health care dollars, and the sickest 5% of our population spend 50% of our health care dollars. So it's a very skewed distribution. So do we have the best health care in the world? A lot of people would argue that. I think particularly for certain conditions, we certainly do. This was a very controversial report from the World Health Organization in 2000 that showed our life expectancy was 47th. In the world, disability adjusted life expectancy was 24th. Fairness to care, however they measured that, was 54th. And they rated the overall healthcare system performances. We were 37th, and France was #1. But clearly, we were the most expensive. Here's some more recent data from 2015, and you can see that our life expectancy and other metrics put us fairly far down the list of the world's developed countries. So one could argue that we probably don't have the best healthcare system in the world. So how do other countries finance healthcare? So there are fundamentally 4 models. One is called the Bismarck model, or the German model. Believe it or not, goes all the way back to 1880s. It's the one that's most similar to our private healthcare insurance system here. The difference is that those health insurance companies are very tightly regulated. Most healthcare insurance is obtained through employers, but if you are have lower income bracket, there's a government subsidy for the unemployed in the lower income brackets, and the countries, these are the countries that use this particular model. The Beveridge model was created after the war, World War II, in Britain. And is known by the National Health Insurance, known as the National Health Insurance Service there. In this model, the government actually owns and operates the entire healthcare system, and the healthcare system is paid out of general taxes. So the patients don't get any bills. About 3% of the total healthcare cost in Britain is actually private. So if you have the money or the means, you can get healthcare in Britain outside of the national healthcare system and cut the line. And that's fundamentally the problem in Britain, is that there's a line for everything. If you need your hip replaced, get in line. But these are the countries that use this particular model. The Canadian model was established by Tommy Douglas really fundamentally in 1961. And in this one, it's a tax-funded government payment for health system, and it's done by the province. So the province pays the taxes. So fundamentally what happens is the province collects the taxes, creates a budget, that's given to the healthcare administration for the province, and that's what's paid for. The doctors in the hospitals are private, but the healthcare for the individuals is paid for by the government. And that's Canada, Taiwan, and South Korea. A lot of people would argue that the reason the Canadian system works so well is because most of the population lives along the northern border of the United States, and if they need to get care in an urgent fashion and have money, they come to the United States and get it in the United States. The last model is the you're on your own model, the Yoyo model. This is the third world model. Vast majority of care is paid for out of pocket. If you have the money, you get health care. If you don't get the money, you don't have health care. Mostly in rural areas of Africa, India, South Asia, China, and South America. So interestingly, we have all 4 models in the United States. The VA system is fundamentally the Beveridge model. Hospitals are all owned by the VA, doctors employed by the VA. The Canadian model is much more like Medicare. The private employer-based models like the Bismarck model, and if you don't have insurance, good luck. So who pays for health care in the United States? About a third of it is paid for by private health insurance, and almost 60% is paid by the public insurance plans, and then the rest a variety of other ways. Keep in mind that hospitals don't cover their costs from the from the public insurance plans, either Medicaid or Medicare care, and so generally what happens is hospitals overcharge private insurance to make up the difference. So what was in the Patient Protection and Affordable Care Act? And you can see all this, but you know, coverage for your kids up to 26. My kids were really happy about that. I've still got one under that. Got rid of pre-existing conditions and created the accountable care organizations. There was a donut hole in Medicare that got plugged for Part D around drug costs. For the first time, the insurance companies became regulated. Medical loss ratio, which is how much of the premium you collect that you actually spend on health care. You had to spend 85% on health care rather than taking you know, inordinate profits. They still take inordinate profits. But it was a first effort to try and limit you know, restrict insurance companies. There were some penalties for avoidable readmissions, trying to improve quality. The insurance exchanges for patients who didn't qualify for Medicaid or Medicare, but also couldn't get employer-based insurance. Remember the disastrous rollout of the exchanges. And then Medicaid expansion. So there was a big expansion of Medicaid. Up to 138% of the federal poverty limit, and fundamentally blue states expanded and red states kind of didn't expand, and we're still fighting back and forth over the Medicaid expansion. And the other thing was there was a mandate to buy health insurance. So you had a tax penalty if you didn't buy health insurance. That's part of what went to the Supreme Court, and that was what was repealed in the most recent tax code. So I'm a pediatric surgeon, so let me focus a little bit on children for just a second. So there are 37 million Medicaid pediatric patients in the United States, and then about 8 million in CHIP, and that's why it was so important for us to have CHIP reauthorized. 40% of kids in the United States are on Medicaid, so that means 40% of kids either have a condition that qualifies for Medicaid, which is usually a chronic illness of one kind or another, or they live within 138% of the federal poverty level. It's kind of sad, actually, if you think about us as a country. But even though 40% of kids are on Medicaid, they only account for 20% of the Medicaid patients. A lot of the spending in Medicaid actually goes for older patients who have complex medical needs. And 60% of the pediatric Medicaid patients go for health maintenance and well child care, and that's for payments that go for pediatrics. Now, there's a lot of talk about block grants. So what do block grants mean? Well, what the federal government is talking about doing is taking the money that is spent on Medicaid, and instead of kind of paying for all the costs, the way the cost sharing goes between the states and the federal government, it fundamentally will cap it, and each state will be given a block of money. It's unlikely that this would be beneficial for children. If you look at the percentage of children covered by health insurance at any given time, it's about 94%, and this is the way they've been covered. When the ACA expanded Medicaid, we actually didn't see much of an impact in the pediatric world because children have, as you can see, for a long period of time, children have been pretty well covered. The big impact in the expansion of Medicaid actually was in the childless adult population, which is why Stanford Hospitals feels the impact of the Medicaid expansion more than Packard does. So what drives Republicans crazy about Obamacare? Just about everything. First of all, it's considered a very large expansion of government, especially Medicaid. And the fundamental push for the very conservative side of the Republican Party and the libertarian movement is actually smaller government. So there's a huge push to try and shrink the government, and Medicaid expansion flies in the face of that. Mandates, again, drive them crazy because this is the government telling you have to buy something, and that's why they repealed it. It went to every length they could to repeal it. Taxes on wealthier people. How do you pay for this? Well, the 1% has to pay for this. Healthcare is expensive, and they see this as a redistribution of wealth. It's got Obama's name in it. And they hate anything associated with Obama. The cost, it's very expensive. And from a coverage perspective, it actually has been far more successful than anybody predicted. And that's got Republicans upset as well. So where are we going? Tough to make predictions, especially about the future, but here's kind of my best guess. There's a lot of potential for further congressional action. The Republicans got pummeled over health care and the rollback of, and so the fact that they couldn't, quote, repeal Obamacare. So the rollback of the mandate was more or less hidden in the tax bill, but there will continue to be moves to try and emasculate the ACA. There's a lot of still talk about Medicaid reductions, spending in Medicaid through block grants. Again, we have to watch that very carefully because I think that will be very unfortunate for children. We just saw work requirements for Medicaid rolled out. I think Kentucky is the first state that's actually going to implement this. This will be implemented on a state-by-state basis. Undoubtedly big legal appeals to this because fundamentally most people who are on Medicaid actually work. They just don't make any money. And then the question is, Paul Ryan is very eager to try to do something about Medicare. This really is, I think, fundamentally the political third rail. Children don't vote, but I can tell you retired people do. And again, going back to that concept that I am entitled to Medicare because I've been paying for it my whole working career, is a fundamentally different attitude towards Medicare than Medicaid. And then the real question is, how do you balance $1.5 trillion in tax giveaway? You got to get money back, and one thing that could potentially go after is the tax deductibility of health insurance contributions. Nobody would have thought they would go after the mortgage deduction, but who knows if Medicare health insurance deductions will be next. So what do we think is going to happen? Provider consolidation is going to continue. But what we're seeing now is we're not only seeing horizontal consolidation, so, two big health companies merging, but we're starting to see vertical integration as well. So health company and a CVS. And I think that's going to continue to try and find new and disruptive ways to deliver health care and lower the cost of health care. I think that consumer-driven health care will continue to thrive. Things like One Medicine, ZocDoc. I have a 27-year-old who was looking for health insurance, and he was having trouble finding something online, and I said, well, you got to pick up the phone and call him. He said, I am not picking up the phone and calling anybody and getting in a queue. He said, if I can't find it online, I'm not doing it. And so, Gen Xers and the younger people are fundamentally looking at a different way to buy health care. Chris Dawes, who's the CEO at Packard, has a 27-year-old son, and Chris said to his son, you have to get a primary care doctor. And he said, I have a primary care doctor. And he said, oh yeah, who's that? And he pulled out his cell phone and he called up the ZocDoc app and said, this is my primary care provider. So younger people have a different attitude toward medicine. Health monitoring devices will change the physician-patient relationship. For some diseases, we are starting to do type 1 diabetes management at home using GlueView, a telephone app that can be continuously connected with the healthcare system. Last week, I was just out in St. Louis visiting something called Mercy Virtual. It is a 4-story hospital outside of St. Louis that has no patients in it. It's completely full of monitoring stations, and they monitor all of the Mercy Health Care network remotely. It's a very interesting concept. Obviously, genomics, omics of every kind are going to completely change the way we have to take care of patients, learn about patients. I'm sure that everything I learned at Harvard Medical School is now completely obsolete. So. And lastly, the cost of medical care is going to have to is likely to drive a fundamental change in the healthcare system. At some point, you know, 22, 24% of GDP becomes unsustainable, and what's going to be the alternative? California is already starting to talk about a single payer. New York is definitely talking about a single payer system. I'm not sure that's the right answer, but there will be very, very profound mechanisms to try and drive the costs down.